Somewhere in your billing workflow, there is a pile of claims sitting in payer limbo. They were submitted, they were acknowledged, but nobody in the office knows if they are actively being processed, held for additional information, or quietly denied. That pile costs your practice real money every single day it sits there. Claim status checking is an unglamorous back-office task, but it operates as a relentless, invisible leak, draining revenue directly from small and mid-sized practices. According to CAQH, manually checking a single unpaid claim takes 14 minutes. That time breaks down into enduring hold times, navigating payer portals, and logging documentation. When dozens or hundreds of claims require missing information, those 14-minute intervals compound into an overwhelming administrative wall. When internal staff run out of hours in the day, these follow-ups are skipped entirely. The claims age in accounts receivable. Critical appeal windows silently close, and expected revenue has to be written off as a complete loss. This line graph maps out recent data from Experian Health, and the trend is alarming. In 2025, 41% of healthcare providers now face claim denial rates above 10%. That number has climbed steadily every single year since 2022. The drivers behind this climb are entirely structural. Payer rules are growing increasingly complex, and the algorithms deployed on the payer side are catching a wider net of technical reasons to reject a submission outright. Kodiak Solutions tracked a 25% increase in net revenue leakage in a single year. That translates to over $48 billion in uncompensated claims. Alongside that loss, providers spent an estimated $43 billion trying to collect payments insurers already owed them. Rising denial rates coupled with massive administrative retrieval costs are pushing modern healthcare practices into an unsustainable structural crisis. A major friction point is the payer portal problem. Every major insurer has its own login system, specific navigation rules, and strict timeout policies. Working through a diverse payer mix requires jumping from portal to portal, wrestling with disconnected systems that actively fight efficiency. Then comes the staffing spiral. When a billing specialist who understands Anthem's specific denial logic or United Healthcare's hold codes leaves the practice, that highly specific institutional knowledge walks out the door with them. This 12-month timeline maps out the HR reality. Medical billing staff average a 35% annual turnover rate. It takes 3 to 6 months to train a replacement up to full productivity, leaving the practice running at severely reduced capacity for half the year. That reduced capacity creates a daily operational paradox. A single billing specialist has to handle charge entry, post payments, field patient billing calls, and manage authorizations. Claim status checking is consistently the task that gets pushed to tomorrow. Attempting to untangle a complex, automated payer data problem using overwhelmed, internally constrained staff guarantees a constant state of financial hemorrhage. Industry organizations like MGMA consistently recommend a strict cadence. Claim queues must be worked daily, not weekly. A claim submitted on Monday can receive a request for information within 48 hours. Waiting until Friday to check it means bleeding critical days off the appeal window. This matrix represents stratification. Operations must prioritize high-dollar claims approaching appeal deadlines. Teams also track denial root causes by specific CPT codes. Continually denying the same code indicates a recurring workflow error, requiring a structural fix, not a random anomaly. Additionally, modern practices maintain strictly separate workflows for initial status checks versus denial follow-ups. Mixing the two tasks in the same queue guarantees both will be handled inconsistently. Achieving this level of relentless daily operational rigor is mathematically impossible without dedicated specialized capacity that most practices simply do not have in-house. This is why smart practices are bypassing the internal capacity paradox entirely. They are moving the entire process off their internal team's plate and delegating it to dedicated claim statusing services like Staffingly. This scale breaks down the financial math. Hiring an in-house billing specialist costs $55,000 to $75,000 per year in loaded compensation before replacement costs. Staffingly executes the same work for $399 per week, roughly $20,700 a year. This lower cost provides dedicated AAPC and AHIMA-credentialed specialists. They learn your specific payer mix and work directly inside your existing EMR, whether that is Epic, Athena, or eClinicalWorks, without the friction of screen sharing. The human expertise is augmented by AI-driven tools. Predictive workload management analyzes the queue and uses smart routing to push high-risk claims directly to the right credentialed specialist before they hit uncollectible aging buckets. Medical claim statusing is an entirely solvable equation. By replacing internal bottlenecks with dedicated AI-augmented human expertise, practices can stop the leak and instantly reclaim the cash flow that already belongs to them.